The next doctor is Dr. Voorhees, and he is going to talk about when myeloma comes back, a very important topic. Take it away, Peter.
All right. Thank you very much, Kelly and Joe. Thank you for the wonderful talk on newly diagnosed myeloma. And also thank you for, providing me the opportunity to participate in this important event. So I'm going to be talking about what happens when multiple myeloma comes back. I'm first going to talk about what relapse is in multiple myeloma. We'll talk a bit about the available treatments for relapse. I'm happy to say that we've got many more options available, and outcomes for patients are continually improving. We'll talk about, kind of what factors we use when choosing optimal therapy for patients whose myeloma has come back. I do want to talk about some of the novel treatments that have recently been FDA approved and those that we hope will be FDA approved in the very near future, and then I'll go ahead and wrap up. All right, so what does it mean to relapse? So the National Cancer Institute has a couple of different definitions here, which I think are helpful. So they define progressive disease as cancer that is growing, spreading, or getting worse. And a similar term, relapse, which is the return of a disease or the signs and symptoms of a disease after a previous period of improvement. We talk about disease progression, progressive disease, disease coming out of remission, relapse, interchangeably. It all means the same thing. So after initial treatment of multiple myeloma with initial induction therapy that Joe has outlined very nicely, with or without transplant, there is a small amount of residual disease left behind. And when those residual multiple myeloma cells kind of come out of hibernation and start growing and dividing, the burden of disease is increasing. And that is basically what it means to have your multiple myeloma come back. And there are a lot of ongoing efforts to better understand the biology of those residual myeloma cells that are left behind after initial treatment, so we can, learn how to better treat those residual cells and get to cure. So how do we identify relapse? So the nice thing, and Joe did allude to this in his talk, is that we actually have a biomarker that we can use to follow multiple myeloma patients. So if you think about prostate cancer, we use the PSA test to follow, whether the disease is advancing or responding to treatment. PSA is a protein that the prostate cancers produce and release into the bloodstream where we can measure it. So similarly, multiple myeloma cells, which are cancerous plasma cells, make a unique antibody that can be identified both on blood and urine tests. And these antibodies may consist of what we call an M spike. Joe also alluded to it as an M protein or monoclonal protein or paraprotein. These terms, unfortunately, are used interchangeably. But an M spike is basically an intact antibody that consists of two heavy chain proteins and two light chain proteins that are complex together, as you can see in these Ys on the right-hand portion of the slide here. And this heavy chain can either be an IgG antibody, an IgA or IgM antibody, and then in rare cases, an IgD or an IgE antibody. The light chain component, which is the two smaller sticks that are complex with the bigger heavy chain sticks, either consists of a kappa light chain or a lambda light chain. It is important to note, though, that some patients do not make or their myeloma cells do not make an intact antibody. They actually just make what we call a free light chain antibody. In other words, they're just making the shorter sticks. So their myeloma will either just be making kappa light chain antibodies or lambda light chain antibodies. And then we have patients where you can actually detect both an intact M spike as well as free light chain antibodies. The M spike or M protein, monoclonal protein, paraprotein, again, these are all terms that are used interchangeably. That's measured with what we call the SPEP test, or serum protein electrophoresis. And then these free kappa and lambda light chains are identified either with the serum free light chain test or 24-hour urine testing. So as far as identifying relapse, it's absolutely critical that patients who've been initially treated for their multiple myeloma are regularly followed with a minimum of SPEP and serum free light chain testing. I would argue, and I think most people would agree, that in the majority of cases, the serum free light chain testing can replace the 24-hour urine testing for measuring these light chain antibodies that myeloma sometimes make. I do want to talk a little bit about what we call free light chain escape. So this is a situation where a multiple myeloma cell that's been making an intact antibody or an M spike loses its ability to do so and actually just starts making the free light chain portion of the antibody. So an example would be, a patient who has an IgA kappa producing myeloma cell. The myeloma cell loses the ability to make the IgA heavy chain portion of the antibody and starts just cranking out free kappa light chains. This is important because free light chains are not picked up well at all on SPEP testing. You would only catch that on serum free light chain testing or 24-hour urine testing. So it's absolutely critical that both measures be followed over the course of time, even if the patient has an intact M spike at initial diagnosis, because it can turn into free light chain disease over time. I also want to make note of what we call non-secretory or oligosecretory multiple myeloma. This is a situation where multiple myeloma cells have lost the ability to make an antibody or make minimal antibody. So the unfortunate thing about this is we cannot use this antibody biomarker that I've been talking about to monitor whether the disease has responded to therapy, and we can't use it to determine if the disease is relapsed. And in those situations, we unfortunately have to rely more heavily on repeated imaging to look for any signs of new bone lesions, et cetera, that are occurring in those patients. And more frequent bone marrow biopsies, unfortunately, are required in those circumstances as well. So imaging is a very important part of identifying whether the disease is coming back or not. Now, in most cases, somebody who has advancing bone disease, will also have an increase in their myeloma antibody, but that is not always the case. So I always advocate for at least once yearly imaging for patients who've been treated into remission, and certainly at the signs of any new bone pain, for example. And there are a number of different imaging modalities that are used to assess for bone lesions. There's the traditional skeletal survey, which is basically a series of plain x-rays of the bones. There's something which will hopefully be used more and more in the United States in the years to come, which is called low-dose CT, which is a more sensitive way of picking up bone lesions in the skeleton. There's a technique called whole body MRI, and then certainly there's CT, MRI, and PET CT that can also identify bone disease. There's a concept called extramedullary multiple myeloma. So medullary multiple myeloma is the multiple myeloma that Joe talked about, which is the myeloma that's in the bone marrow. So medullary myeloma is bone marrow myeloma. But for those that have more aggressive multiple myeloma, those myeloma cells may actually mutate in such a way that allows them to be able to grow outside of the confines of the bone marrow microenvironment. So I'm talking about myeloma masses that may present in muscle, soft tissue, liver, lung, et cetera. And that's something that's best monitored with PET CT or CT or MRI imaging. And then obviously we're always assessing when we see our patients in follow-up for any new symptoms that would suggest progression of disease. And that would include progressive new bone pain that we cannot otherwise explain away, or worsening fatigue that, again, we can't explain away. All right, I want to talk about two different kinds of relapse. In the myeloma biz, you'll hear us talking about biochemical and clinical relapse. So biochemical relapse is when the myeloma biomarkers, in other words, the M spike or the affected free light chain, are rising, but there's no clinical signs or symptoms of disease. We're not seeing new bone pain or new bone lesions. We're not seeing progressive anemia, elevated calcium, the features that Joe talked about as far as CRAB features. And there is more freedom of treatment choice in this particular scenario. In some cases, the progression may be so slow that you may not need to make a change in therapy immediately. It may just be a modest change over the course of time, and you just simply need to tweak what you're currently doing. And then there are going to be those situations where you definitely need to change treatment altogether. And the pace of progression and the characteristics of the disease at original diagnosis are important factors that will help us determine which of those three strategies is optimal for a particular patient. And then we have clinical relapse. What that means is that not only has the disease come back, but the patient has signs and symptoms of advancing disease, whether it's worsening anemia, worsening kidney function, new bone pain from progression of bone disease, an increasing calcium level. These are patients, that do not benefit from just continuing the current therapy or tweaking the current therapy. These are patients that need to go on to completely different therapy. So, Joe alluded to the fact, that myeloma is a disease that we, don't cure. And I think most of us in the myeloma community largely agree with that. I will say, though, that there are probably a small minority of patients, who go into remission and stay in remission for many, 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 many years and wind up passing away of unrelated causes many years later. This is a study that kind of supports that notion. So this study came out of Spain, and they looked at 344 patients that had been transplanted back in the days when transplant was brand new, so between 1989 and 1998. So these are patients that we have very long follow-up on. And what they showed is that for those patients that went into complete remission, which are represented by the blue lines here, when you go out beyond 12 years, there's a plateauing in the curve. In other words, if you've maintained that complete remission for beyond 12 years, they weren't seeing their patients come out of remission. Now, I think we all argue about exactly what proportion of patients actually fall into this category, but there are long-term remitters who stay in remission and never come out. And obviously, it's our job to make sure that that blue line continues to rise and actually gets to horizontal, like Joe said. So when can we expect relapse? This is a question that I actually get a lot in the clinic. So patients been through initial therapy, and now they're wondering, when is the disease going to come back? And I think that this is a very useful study to kind of wrap our brains around this. So this is a study that actually came out of the Emory Myeloma group, and they looked at 1,000 consecutive myeloma patients that were treated with what we would consider modern optimal therapy. So they got the VRD regimen that Joe mentioned in his talk. For those that were eligible, they went on to stem cell transplant. And then when they recovered from their transplant or their initial therapy, if they didn't get transplanted, they then went on to maintenance therapy, which in the majority of circumstances consisted of Revlimid alone. But for those patients with more high-risk disease, they actually usually got 2-drug maintenance therapy. And what you can see here in the left graph is that the median progression-free survival was 65 months. So what that means is the median time to multiple myeloma coming back from diagnosis was 5 years and 5 months. That means that half of the patients relapsed before 5 years and 5 months, but, glass half full, half the patients are actually relapsing beyond 5 years and 5 months. And this is absolutely unprecedented and certainly far better than what we were doing 10 years ago. When you look in the non-transplant setting, this is the Maya study that Joe showed earlier. This was Revlimid and dexamethasone versus Darzalex Revlimid and dexamethasone. And as he had mentioned, the 3 drugs outperformed the 2 drugs. And when you go out to 4 years, progression-free survival in the 3-drug arm is 60%. So that's really quite remarkable for a group of patients that did not go through stem cell transplant. So for somebody getting Darzalex, Revlimid, and dexamethasone without a transplant, the expectation is that 60% of those patients will still be in remission and alive 4 years from initial diagnosis. So this is a cartoon that basically came from a study that was published many years ago by Shaji Kumar and colleagues at Mayo Clinic back in 2004, basically outlining the natural history of relapsed multiple myeloma. And to make a long story short, with each relapse, the duration of response to subsequent therapy shortens. I do want to highlight, the duration of response for first regimen, second, third, fourth, et cetera. And I want to compare that to what we're doing now. So again, this was a study that was published in 2004. These were patients that were treated from January of 1985 through December of 1998. Median duration of response for first-line therapy was right at around 10 months. And then it drops to 7 months for second treatment, drops down to a half a year for third treatment, et cetera. So let's flash forward to the present. So I've basically just taken several different phase 3 studies that have been performed, either in the frontline setting, first relapse, second relapse, third relapse. And here we have median progression-free survival of 50 months in frontline, 44.5 months in second line, close to 30 months in third line, and then a little over 10 months in fourth line. So we're clearly doing far better than we were, back in the 1990s. But it is important to recognize that the duration of response does shorten with each relapse. So the take-home message here is that you really need to put your best foot forward. You need to optimize the duration of remission early in the course of the disease. And importantly, the longer the remission, and I always say this for patients who are considering transplant, the longer the remission, the more treatments you'll have available at the time of relapse with the pace of FDA approvals that we're seeing. So this is just a laundry list of various drug classes that are available for relapsed multiple myeloma patients. We talked about the IMiDs before, which consist of Revlimid and Pomalyst, the proteasome inhibitors, which consist of Velcade, Kyprolis, and Ninlaro. We have the alkylating agents, Cytoxan and Melfluffin, and in some instances, bendamustine or Treanda that people may be familiar with. We have the histone deacetylase inhibitor, Faradex or panobinostat, the antibodies such as Impelicity, and then the CD38 antibodies, isatuximab or Sarclisa, and daratumumab or Darzalex, and then every patient's favorite, the steroids, dexamethasone and prednisone. But I do want to give a few shout-outs here. There is a new spin on an old idea, a new inclusion to the alkylating agent family, which is something called Melfluffin or melphalan flufenamide, which we'll talk about in a moment. We have a completely new drug class called Bcma targeted therapy, and the first one that's received FDA approval is something called belantamab mafodotin or Blenrep that was approved in the summer of 2020. And then we also have the exportin-1 inhibitor called selinexor or Expovio. Actually, I'm just going to go back here really quickly and just mention, that there are actually, if you look at the National Comprehensive Cancer Network guidelines for the treatment of relapsed multiple myeloma, there are actually 45 regimens that are listed as possibilities. There are 9 regimens that are the preferred regimens, and those are the ones that most of us commonly use, but there are 19 others that are recommended, and then there are 17 that are useful in certain circumstances. And I just want to highlight this because, it gets incredibly confusing about, which regimens that you should use, and this is why having a myeloma specialist in your care can be helpful. So how do we make decisions about treatment in the relapse setting? This is a slide that I've shown in many other presentations, but I think it's very helpful, in just kind of outlining exactly how we make decisions about treatment for myeloma patients with relapse disease. The P in PAPS stands for past medical history. What comorbidities or other diagnoses does the patient have that could impact, safety of a particular regimen? So, for example, someone with a significant heart disease and congestive heart failure may not be a good candidate for Kyprolis. And then somebody who has bad diabetic neuropathy may be a bad candidate for a Velcade-based strategy. The A stands for adverse events. So we have prior history of treatment in the frontline setting to help guide decisions at the time of relapse. So what toxicities were experienced with prior therapy? So for example, if a patient received Velcade-based therapy in the frontline and experienced painful neuropathy related to it, you probably aren't going to go to a Velcade-based strategy in the relapse setting. But if their disease responded beautifully to the Velcade-based strategy, you may consider them for Kyprolis, which is in the same family, but has a far lower rate of neuropathy. The B stands for biochemical versus clinical relapse, which I talked about before. Again, with biochemical progression, you can do clinical relapse really requires a completely new treatment strategy. We look at standard versus high-risk disease biology and cytogenetics or FISH testing. Looking at the chromosome changes of the myeloma cells is very important. We oftentimes will repeat that testing at relapse to see if someone with standard risk disease has evolved into high-risk disease, in which case we may need to treat the disease more aggressively. And then the T, and this is a really important one, stands for treatment history. What has the patient received in the past? And are there specific drug classes that their disease is resistant to? In that case, you typically are going to want to gravitate away from those same agents if you have the choice. All right, so I'm going to talk about two what I call Trojan horse approaches to treatment of multiple myeloma. These are the newest kids on the block. These are just recently FDA approved. Melfluffin flufenamide, or Melfluffin, which was literally just FDA approved within the last several weeks. And then belantamab mafodotin, or Blenrep, that was approved back in the summer of last year. So starting at the top, so this circle here is a myeloma cell, and then you see this again, this Y-shaped stick-like structure, which is an antibody. Belantamab mafodotin is an antibody which binds to a plasma cell-specific marker that sits on the surface of the myeloma cell called Bcma, or B-cell maturation antigen. Now, interestingly, what they've done is they've actually attached a chemotherapy drug to this antibody. So what happens is that the antibody specifically binds to plasma cells, including malignant myeloma plasma cells, which can incite an immune response to the disease. But what happens next is really clever. So the antibody actually gets gobbled up by the myeloma cell, and then that chemotherapy drug that's attached to the antibody is clipped off and released inside the cell to release havoc on that multiple myeloma cell. So it's a way of delivering non-targeted therapy in a targeted manner with the use of an antibody directed against BCMA. Now let's go down to the bottom where we'll talk about Melfluffin, or Melfluffin flufenamide. And what this is an alkylating agent, melphalan, essentially, that's attached to a peptide. Now, the chemical structure of this is such that it freely floats, across the surface of the myeloma cell inside. There are what are called aminopeptidases, which are enzymes which basically clip little proteins or peptides into smaller pieces. And what these aminopeptidases do is they actually clip melphalan flufenamide, releasing melphalan inside the myeloma cell to wreak havoc on the DNA of the myeloma cancer cell. Now, the reason this is somewhat targeted therapy is that aminopeptidases, which are present in all cells of the body, are actually present at much higher levels in myeloma cells, as well as other cancers. So you can actually deliver a higher dose of melphalan to tumor cells than you can to normal tissues, which is what makes it somewhat more selective. So what led to the approval of these agents? So there was the DREAM-2 study, which was a phase 2 study for patients with heavily pretreated, very resistant multiple myeloma. At the recommended dose, the overall response rate was about 30%. So 3 out of 10 patients had at least a 50% knockdown in disease burden. Now, importantly, for those 30% of patients that responded, their average response time, or median response time, was close to a year. So while it is unfortunate that 7 out of 10 patients did not respond to this therapy, for those that did, it actually was quite durable. Similarly with Melfluffin, so it was the phase 2 Horizon trial that led to FDA approval. Again, this was a heavily pretreated myeloma patient population with very resistant disease. And again, they saw a response rate of approximately 30%. The responses were not quite as durable as was seen with the belantamab mafodotin, where it was close to 6 months as opposed to close to a year. But certainly, useful advances in myeloma therapy. Now, as Joe mentioned before, in many instances, combination strategies and triplets, as he referred, are more effective in myeloma. And there's actually several triplets with these new drugs that are being explored in clinical trials now. And I just want to highlight a couple of these. So belantamab mafodotin has been combined with Pomalyst and dexamethasone in relapsed multiple myeloma patients through a consortium of sites in Canada, actually. And what you can see here is that the overall response rate in early days is close to 90%. So contrast that to the 30% that I just showed you, which is really quite remarkable. There's also another study being done looking at various combination therapies with Melfluffin, and this is Melfluffin with Darzalex and dexamethasone, and there the response rate is close to 3/4 of patients, which is really quite remarkable. So it'll be interesting to see how these drugs perform in combination therapy in the months and years ahead. I wanted to talk about venetoclax in multiple myeloma, or Venclexta. So about 15% of myeloma patients will have a chromosome abnormality in their myeloma cells where chromosomes 11 and 14 are fused together. And this is not a bad thing, but it's actually something that we can take advantage of therapeutically. So there's a drug called venetoclax or Venclexta, which is already FDA approved for chronic lymphocytic leukemia, which is a different type of blood cancer, as well as mantle cell lymphoma. And interestingly, Venclexta is particularly active for patients who have this particular cytogenetic abnormality. So if you looked at a study, a phase 1 study in relapsed multiple myeloma with just Venclexta alone, no other drugs, the response rate to the drug was actually an impressive 40%. Whereas those that did not harbor the 11-14 translocation, the response rate was only 6%. So clearly more active in patients with 11-14 translocated disease. Now, again, getting to this notion of combination therapy, so there's a study that's ongoing right now, and one that we have open at LCI, which is looking at Venclexta with Darzalex and dexamethasone for patients with relapsed myeloma that harbors that 11-14 translocation again. And here, the overall response rate is close to 100%. So out of the first 24 patients, granted small numbers of patients, but 96% response rate, and everybody is achieving at least a 90% or greater reduction in disease burden with this combination, which is really quite remarkable. And in early days, when you go out a year and a half from the start of treatment, 94% of these patients still have not progressed. That's really quite remarkable. All right, so let's just talk last about CAR T-cell therapy. As many of you know, the FDA is currently weighing whether or not they are going to approve ide-cel, or BB2121, as the first FDA-approved CAR T-cell product in multiple myeloma. We actually should hear about that within the next week or so, and that's what I'm going to discuss. So what is a CAR T-cell? So CAR stands for chimeric antigen receptor. And this, little cartoon that's sitting on the surface of this T cell here is the chimeric antigen receptor. So
Pete,
on the
I'm sorry to interrupt you, Pete. Just we're running late, so just get you to wrap it up relatively quickly. Sorry, my friend. Thank you.
All right, no problem. So the CAR is sitting on the surface of the T cells, and it actually attaches specifically to the myeloma cell, again through Bcma. And when that happens, it transmits a signal inside the T cell to go ahead and kill the myeloma cell. So what we do with CAR T-cell therapy is we have the patient undergo what we call leukapheresis. So we get a blood sample, we isolate their T cells, we literally introduce this chimeric antigen receptor inside their T cells and expand them into larger numbers, and we basically give them back to the patient. And these are results of the phase 2 study of ide-cel in multiple myeloma that were recently published in the New England Journal of Medicine. And as you can see here, again, in a very heavily pretreated patient population, 75% of patients responding to this single one-time therapy, in contrast to just 31% for those that got Blenrep. Progression-free survival, is a very respectable, approximate 1 year. So, on the one hand, it does not appear to be a curative strategy. On the other hand, this is the best treatment that we've ever seen in this space to date. So to conclude, treatment of relapsed myeloma is complicated. There are many regimens and many factors to weigh in making choices. That's why having a myeloma specialist involved in your care can be quite helpful. Survival for patients with relapsed myeloma continues to improve, and there are many new options available with novel mechanisms of action. Immunotherapy options on the horizon promise to improve survival even further. including ide-cel, other CAR T cells, as well as bispecific antibodies. And then lastly, and most importantly, these improved outcomes could not be possible without the brave and altruistic involvement of patients in myeloma research. We would not have these drugs if patients did not, elect to participate in clinical trials. And for those of you who have the opportunity to do so, I would encourage you. And with that, I'll finish up. Thank you.